Now coming on to our first section, that is we'll be discussing briefly the osteotomies. That is, what is osteotomy? Osteotomies is actually breaking the bone in such a way so that it can be fixed after correction of angulation. Briefly be discussing in this section the limb axis and its reference angles which are used, especially in the case of lower limb. Rules of osteotomy, that is when we have to perform certain osteotomy, whether it has to be open wedge, what is closed wedge osteotomies, and how to calculate cora and where to perform, whether above the deformity, below the deformity, do we have to perform multiple osteotomies at a time, and then complication of osteotomies and deformity corrections. Obviously, as you know, with every surgery there's definitely some kind of a drawbacks or complications, so no surgery is without complications. So we have to understand that whatever we are performing on the patient, this can also lead to some adverse things such as certain complications. So what is osteotomy? It may be used to correct deformity, to change the shape of the bone, or to redirect load trajectories in a limb so as to influence joint function. If you see this diagram closely, and this is the lateral side, this is the medial side. So it's actually the tibia is tilted like this. So this, we can say this is more of a genu varum, that left knee, if you're looking at this. So what is happening over here is there's increased medial joint loading during the walking. This patient would have medial joint arthritis, there would be increasing problems, there will be pain on the medial side, and patient would have severe difficulty, especially climbing the stairs up and coming down from the stairs. So if the age permits, if the patient is young and we cannot go for total knee replacements, which nowadays with the advent of total knee replacement, joint replacement surgeries, although the incidence of osteotomy has actually gone down, but yes, if the patient falls into that typical criteria where we can perform a high tibial osteotomy, if we do something like this, that instead of having it a lateral opening wedge osteotomy, wouldn't this level the joint load of the medial side, as you can appreciate it over here? So this is actually the purpose of osteotomy, is actually used to either correct the deformity, which could be disabling, which could be problematic for the patient, or to unload a certain area of the joint so that the load is actually shared by the other area which is normal, and the area which is diseased is actually redirected away from the loading area of the area. So what is corrective? It can be used for corrective surgery, which actually balances the extent of operative interventions. At times we have to, despite going certain TKR and doing the knee replacement, still have to go some kind of osteotomy because of variation, the problems with the tibia. That is to produce an anatomical normality. Now this has actually resulted in, although performing an opening wedge on the lateral side has resulted in anatomical normality. Then it could be for anatomical correction. That is desirable in the most cases, but not always necessary. For example, instead of a problem at the joint, this could be problem somewhere lower down in the diaphysis of the tibia. But if it is not actually getting hampering the gait, or there is no actually it's not a nuisance for the patient, and there is no actually degenerative changes in the joint, we don't need to really just to correct the limb alignment is not an option. We have to make it sure that yes, we need anatomical correction, but only if it is getting this non-anatomical deformity is actually creating problem for the patients. If it's not creating problem for the patient, we do not need to correct the bones, we need to treat the patients. Now, how we can actually correct the deformity? If you see this diagram again, what is happening over here, there was some kind of epiphysiodesis for limb length discrepancy which is done, probably this, and what has actually resulted in that there is increased loading on the medial side while there is decreased loading on the lateral side. There was probably some kind of a high tibial osteotomy done later on. Now when you are going for the TKR, you need to be extra careful because there will be some bone losses, there will be some problems with the tibia. Tibial axis will not be normal. So before we proceed to correction of deformity, we need to have a coronal and sagittal plane analysis. That is, we need to get an AP view so that we can know what is the sagittal actual abnormality, that is in anterior posterior plane, and then we need to get a lateral view as well to understand what is a coronal plane deformity, that is from medial to lateral plane. So that is important. We can also, nowadays it's with the advent of CT and 3D CT, actually it's very easy to analyze deformity, and it actually gives you a 3D view of the deformity. If there is only corner and sagittal imbalance, or there is also rotational imbalance as well, whether if this deformity is only associated with either genovarum or genovalgum, or there is procurvatum or recurvatum of the tibia as well. So that is how it's going to actually tell us. We can use 3D printing for customized fixation plates as well. This actually ensures accurate planning, because operatively, even a slight variation of almost more, if we distract too much the bone or overcorrect the bone, this can actually lead to disaster complications such as neurovascular injury. So we have to be very sure, meticulous about the planning, that what we are going to do before we undergo surgery. So limb axis and reference angles are important in lower limb. What is the mechanical axis of the limb is defined by imaginary line connecting center of the most proximal major joint to the center most distal. So for example, we are taking it as example of a lower limb. The major joint is actually the hip joint. So this limb's mechanical axis starts right from here, the center of the head of femur, and goes all the way down to the center of the ankle. So in a normal limb, when this center crosses the knee, it's almost to the center of through the tibia, although not exactly through the center, but almost to the center. So in a normal limb, this is how the normal alignment is. But if you see this diagram, you can appreciate the femur is highly deviated. This is actually going away from the deformity. But if you appreciate closely over it, it's not just that it's going in one plane, that is in coronal plane, it's 20 degree away. If you see it on the lateral view, it's also in a kind of a recurvatum as well. So this is actually the important. We need to view, that is why we need 3D options, because we need to understand how much there is deformity in one plane, that is in a sagittal plane, how much in coronal plane, and is there any rotational abnormality present as well or not. Then actually we have to understand that usually it passes, as I told you, close to the knee joint, almost to the center of the knee joint. In deformity, it is displaced away, as you can appreciate in this diagram. If deformity is at two levels, sometimes what happens is that although the bone is deformed, but actually if there is at one level it's 20 degree away from the axis, another level is 20 degree towards the axis, so the overall limb's rotational profile will not be affected much, and patient gait may not be hindered at too much extent. But we have to understand it. If usually what is although very rare, but yes, it can happen, that there are two deformities which are actually exactly opposite to each other and may cancel out each other in a overall 3D profile. So how to screen for it? Basically, we have to compare these reference angles to the opposite limb. That is, usually we have to first calculate the mechanical axis. We have to calculate femoral anatomical axis, which is passes through the center of the diaphysis of the shaft of femur. Then tibial diaphysis angle has to be calculated, and then mechanical and anatomical axis has to be calculated on the both sides. If we are dealing with the one limb only, then we have to calculate on the other limb as well, because we have to understand what is the opposite normal as well. So at the hip, it's actually the angle between the anatomical axis of the femur and the femoral neck. As I just told you, the anatomical axis femur actually passes straight through the shaft of the femur, and a femoral neck is actually, it's through the center of the neck of the femur. So it's around 128 degrees plus minus 3 degrees. On average, it's usually, and some boxes taken as 135 normal, some take it as a range of normal, that is from 120 to 140, but on average this is there is always slight variation in different population, but this is usually taken as normal. Coming to the at knee joint, it's the angle between the axis of the tibia, which is actually the anatomical axis of the tibia is a line passing through the center of the tibial diaphysis, and tangent line to the line of the knee. That is actually mechanical, where the mechanical axis bisects the knee. If you draw a tangent that is direct to the center of the angle, that is the limb and reference axis of the tibia. On the it's slightly on the medial aspect, and usually it's 87 degrees plus minus 2 degrees, which is almost you can say this is near to 90, which means it's the tibial, anatomical and mechanical axes are almost parallel. Now coming to the other axis, usually as I told you, it's the angle between the anatomical axis of femur and tangent line to the joint line of the knee. It's actually 80 degrees plus minus 2 degrees. Now that is actually calculating the reference angle between the anatomical axis of femur and the mechanical axis of the tibia. Now at the ankle, you have to calculate with respect to the tibia. Angle between the axis of the tibia and tangent to the tibial plafond, and it usually lies on the just lateral to the center of the tibial plafond, and it's approximately 89 degrees plus minus 2 degrees. Then again it's almost 90 degrees, and you can say that the tibial axis and the anatomical axis of the ankle is almost parallel. Now coming to the rules of osteotomy. In contemporary deformity analysis, intersection of anatomical axis is called the center of rotation of angulation and can be determined by noting the intersection of mechanical axis of segments proximal and distal to the deformity. So we have to calculate CORA before we proceed for deformity correction. For example, if the bone has one deformity and has two ends, one end would have a different axis, another distal end would have different axis. We have to calculate how much the CORA is between them two, and where actually the center of rotational axis lies. Is it above the deformity? Is it at the level of deformity? Or is it below the level of deformity? That is how it determines whether we have to perform one osteotomy at the level above or below, or we have to perform multiple osteotomies. So indicates the placements of angulation of correction axis, that is where we have to correct the deformity. For deformity correction, appropriate realignment of intersection axis is important. Position on the either side of the CORA. Now, if there is a deformity, the intersection could occur either above or below or at the level of the joint. But usually at the level of deformity is highly rare, so it's either above or below the level of deformity. So that determines whether we have to perform an opening wedge or a closing wedge deformity, so that if we correct the deformity in the opposite direction. Sometimes what happens is with simple opening wedge or closing wedge deformity, although the angulation is corrected, but as it's not correcting it in 3D plane, so it actually produces a translation deformity which might be present as well. If you see this diagram over here, now this is the proximal segment, this is the distal segment. We have calculated the axis over here and the center of axis over here. We know this is the intersection point, and this is the angle of angulation of correction axis which is needed. Now this is the point where it's correcting itself. So this is the deformity, and CORA lies above the level of deformity. So if we are correcting it in only one plane by producing something osteotomy, either opening and a closing wedge, the proximal distal segment, although this will correct the deformity, the axes are corrected, but if you see clearly, this produces translation of the two joints. That is, if we have corrected deformity in one plane but in another plane, this resulted in translation of the movement. So that is what is important. We need to view it from sagittal plane, lateral view as well. And we need to view it from corner plane and also get a 3D view, whether is there any rotational element of the deformity is present or not. So if this rotational element, it actually indicates multiple apical deformities. CORA within the boundaries of the bone if it is involved, coinciding in the level of the apex of deformity. If you see at this level, its apex is above the level of deformity, not at the level of deformity. Therefore, angular component of the deformity rotation axis can be sighted or bisected. That is important, that if you analyze this thing, this is where the axis of rotation is actually happening, and this is where we need to do the osteotomy. Osteotomy is at the same level, usually equivalent to opening and closing with methods. That is, if you see over here, the CORA lies above the deformity, you have to perform at this level, not at the level of deformity. Otherwise, if you perform osteotomy in form of opening or closing wedge at the level of deformity, this would produce a translational problem, as you can appreciate in this diagram. So coming to the CORA within the boundaries of the bone involved, different level to the apex of deformity, presence of translation and angulation would be present, and usually rotation axis has to be calculated on the bisector. Then we may have to perform osteotomies at two levels. First level is, and the first method actually to perform at this is correction of translation and angulation at the original deformity site. That is, we have first correct the translational problem at the original deformity site and then perform osteotomy above or below the level of the deformity where the cora is actually performing. Second option is creating a new deformity which actually balances the malalignment of the original site. So if there was 20 degree of varum, we can produce 20 degree of valgus at another site so that the overall limb rotational axis is actually balanced. Second option is, instead of performing two osteotomies at a different sites, one above and below the deformity and one at the level of deformity, the second method is, if the cora is outside the boundaries of the bone involved, then presence of multiple apical deformities can be done. Multiple osteotomies can be done so that it corrects the deformity in all planes. One osteotomy is correcting in sagittal plane, in coronal plane, and another is correcting it in a rotational plane. So multiple osteotomies for resolution can be an option in that case. So as you know, with every surgery there are always some complications. What are the complications of performing osteotomies? Generally they include thromboembolism, because patient is really bend bound, and there is venous stasis, as mostly these limb deformities are associated with lower limb problems, so therefore the patient cannot walk straight away. They may be associated with infection as well. Undercorrection or overcorrection is a major problem. Sometimes we, even despite the meticulous planning, at times you undercorrect the deformity and there is always some residual deformity which remains. Or the problem is, initially there was a problem with genu varum, overcorrection has been done and now it's genu valgum. The problem is there will still be a problem with the patient in walking and carrying on the activities of daily living, because both the genu varum and genu valgum beyond a certain limit can be problematic for the patient. Therefore, preoperative planning, radiographs and fluoroscopy is important, post-operative radiographic check is important, and post-operative radiographic measurements has to be done as well, that how much correction has actually taken place. Then it is the nerve tension. As you know, that correcting too much of a deformity straight away can actually result in a nerve traction injuries or neurovascular bundle compromise, especially if it is more than 20 degrees of nerve traction is done. This can be highly harmful for the patient in case of a peroneal nerve injury. For example, if the patient had genu varum and too much of this, for example, the patient had genu valgum and too much correction has been done, this can eventually lead to stretch on the peroneal nerve and leading to peroneal nerve palsy. Other problems include compartment syndrome. Although osteo usually associated with osteotomy with tibia and forearm bones, but forearm bones osteotomies are rarely done. Mainly we are dealing with problems with the tibia. It's a limb threatening complication and must be avoided and must be repeatedly checked for the signs, especially the passive pain out of proportion, pain with the passive range of motion. These are the earliest signs which actually emerge in the compartment syndrome, and patient must be evaluated for after deformity correction. If for example you suspect compartment syndrome post deformity correction, then one must undergo fasciotomy so that the compartment syndrome can be avoided. Then comes the non-union. If fixation is inadequate, or if there was too much movement at the fixation site, or for example the patient was bed bound, or patient had some kind of infection post-operatively, then this eventually would lead to non-union, which could be hypertrophic or oligotrophic depending upon what were the circumstances which eventually led to non-union. So there has to be, then that has to be dealt separately, because a non-union itself a problem, and that has to be done with, we may have to initially first fix the bone with the plate and along with the bone graft once the infection resolves, and then later on again we go for some kind of a surgery for deformity correction. So non-union is actually kind of complicates the surgery, because then we have to go for multiple surgeries at a time to rid the patient of first the infection, then of the non-union, and then probably lastly we may have to go for deformity correction. In this section, we have briefly gone through what are the different types of osteotomies, how to calculate cora, and whether how to move about performing the osteotomy at what type of levels. Normally you have to understand that we have, before going for the osteotomy, you have to plan meticulously, get the 3D view of it, 3D scanning of it, and then get x-rays in sagittal and coronal plane as well, so that we know that what kind of deformity we are dealing with. Calculate the cora so that you know that you have to perform one osteotomy, multiple osteotomy, whether you have to perform osteotomy at the level of the problem or above the level of problem. So by this method, we can meticulously plan and carefully involve other modalities so that we can correct the deformity of the patient, especially with the lower limbs. Thank you very much. Keep watching sqadia.com.